Well, good afternoon, everyone. On behalf of the National Sheriff's Association, the Health and Reentry Project, and the National Association of Medicaid Directors, welcome to today's discussion on the new Youth Continuity of Care Requirements, Fostering Cross-Agency Collaboration. A few housekeeping notes before we begin. This webinar is being recorded, and a link to the recording as well as the PowerPoint slides will be available in the upcoming days. The use of AI recording is strictly prohibited. We ask that you do not activate a recording or transcription tool during today's discussion. And please submit any questions in the Q&A, which can be located in the 3 dots right next to the chat button. And with that, I'd like to take a minute to introduce our distinguished panel. First, Dave Ryan, who is the Senior Director of Criminal Justice Initiatives with HARP, the Health and Reentry Project. With HARP is Margot Cronin-Furman, and she is the Chief of Staff for HARP. Number 3, joining us today is Hannah Maniates, Senior Policy Analyst at the National Association of Medicaid Directors. With us also today is Mike Levine, and Mike is the Massachusetts Assistant Secretary of Health and Human Services and the state's Medicaid Director. And last but not least, Rick Bishop. Rick is the Jail Liaison with the Washington Association of Sheriffs and Chiefs of Police. And my name is Carrie Hill, and I am the Executive Director of the Massachusetts Sheriff's Association and the Chief Jail Advisor to the National Sheriff's Association. We are thrilled today to lead the discussion on the new continuity of care requirements as laid out in the Omnibus Consolidated Appropriations Act of 2023, which goes into effect on January 1st, 2025. You will hear more about the specifics of the Consolidated Appropriations Act, or CAA, from our panelists. In September of 2024, the Bureau of Justice Assistance and the National Institute of Corrections hosted an all-sheriffs authority meeting, bringing together sheriffs from across the United States. And during that convening, the discussion focused on the upcoming requirements of the CAA. And one of the significant takeaways in this intersection of public safety and public health is the importance of the collaboration between our nation's sheriffs and their state Medicaid directors. For purposes of today's discussion, you'll hear how together the relationship between the sheriffs and the state Medicaid partners can help you achieve the new Medicaid requirements, with the ultimate goal of improving health outcomes for those returning to our communities. And with that, I'd like to turn it over to Dave Ryan, my dear friend, to take us through this journey and learning more about these new youth continuity of care requirements. Dave?
Carrie, thank you so much. And I'd just like to take a moment to thank NSA and NAMD for hosting today's important discussion on the new youth continuity of care requirements. Just a little bit more background about myself. Prior to joining HARP back in April, I spent over a decade working in a local jail and working specifically on these issues at the intersection of justice and health. But wanted to also provide just a little bit of background and grounding about the Health and Reentry Project, or HARP. HARP was established to improve the health and safety of people and communities. So our goal is to help folks return healthy and whole to the community from incarceration. How do we do that? It's through education and analysis that we work to strengthen policy and expand access to care for individuals. There's 2 main areas, one of which we're going to get into in great detail, which are the youth provisions, which, as Carrie cited, go live on January 1 of 2025. The other that I'll just touch on briefly, just to kind of make the distinction, are the 1115 Medicaid demonstration opportunities, which I'm sure a lot of folks on the call are aware of. HARP works to advance implementation of these new policies by working with state and local agencies. We are currently working in 7 states right now through our Learning Collaborative with our partner NASHP, the National Academy of State Health Policy. We're also working in 12 other counties in California to help aid the implementation of the 1115 waiver provisions. Lastly, we see ourselves as conveners. I think, which is demonstrated by this call today. There's not a long history of these two systems with justice and Medicaid agencies talking to one another. There are some great examples, and we're going to hear from Massachusetts later on today about their great work in this space. But we try and convene diverse sets of stakeholders in order to inform our work as we're moving forward. And that's actually how HARP launched back in 2022, was by convening 70 stakeholders around a table, because we all identified the issue, but we wanted to identify a path forward. And it was through that stakeholder collaboration that we're able to do that. We can go to the next slide, please. So I think it's important to, again, just kind of pause for a moment, that this is a public safety issue, and we have an opportunity here to improve continuity of care for those that are returning to community and improve their health outcomes. But in addition to that, we have another opportunity to be able to reduce recidivism rates and also future law enforcement interactions for individuals who are returning by providing coverage to Medicaid, but also a connection to care within the community, because the research is suggesting at this point, if we do both, provide the coverage and a connection to care through case management, we have an opportunity here to reduce law enforcement interactions in the future. So folks with acute care issues could be better served by receiving that care within the community as opposed to a jail or an emergency department, for example. Again, we also have an opportunity here to prevent death, especially due to overdose post-release. I think a lot of folks on this call are aware, like, that first 72 hours post-release is a really perilous time for folks that are reentering, and sometimes a tragic outcome. We also want to work to prevent unnecessary ER visits and hospitalizations, because as we all know, that the ED is not always the best place to be getting your primary care. And also reducing racial inequities in our criminal justice system. And also, we view this as a correctional officer wellness issue, because when you have folks that are in your custody, as many on this call know, with acute care issues, it's very taxing on staff. And so we're hoping if more folks can receive their care in the community and stay in community upon reentry, that this will actually also improve the climate where folks are working, and also for those folks that are in custody. The one last study that we wanted to cite was from 2022, just as an example, that having Medicaid coverage reduces rates of incarceration by an estimated 40% among young men with mental health conditions in South Carolina. So that's one study that we lift up often for folks to illustrate the public safety piece of this. So now the reason why we're here today is to start to dig into the new youth continuity of care provisions. I think, again, not to belabor the point, but it definitely bears mentioning, is that these go live January 1 of 2025. Many states across the country are heads down right now, working through the implementation pieces in order to make this happen. But I think it's also important to step back a little bit and talk about who this applies to. So we're talking about post-adjudicated. There is another option, which I'll get into later on, which has to do with pre-adjudicated and folks that are awaiting trial. The 5121, as it's referred to, this is for post-adjudicated folks that are under the age of 21 or former foster age youth under age 26. And the policy requires two things of all states. One is to provide screening and diagnostic services and referrals for youth 30 days before release or shortly thereafter, so that it can occur in the community. And so those are important considerations for correctional administrators in working with their state office of Medicaid to determine what those services need to be. In addition to that, folks are going to be provided targeted case management within 30 days prior to release, and then 30 days following within the community. So again, there's going to be a need for collaboration in what that looks like from the correctional facility standpoint, but also in working with your state office of Medicaid. And you'll hear me probably multiple times during this webinar talk about the need for that collaboration. In this, again, there's probably not a long history of folks coming together and talking about some of these issues, but in order for this to be successful, both systems have to come together and collaborate on the implementation. So this applies to all state, local, and tribal facilities where youth are incarcerated, post-adjudication, so that's prisons, and for the purpose of this called jails, juvenile justice, and youth corrections. I will say when I first saw this, when I was working at the jail, I actually didn't think that it applied to us because I thought this was just for youth, but because of the federal definition, we're pulling in folks under the age of 21 and former foster age youth under the age of 26. So that's why it brings in the adult correctional facilities. Because a lot of our conversations when we talk to jails is that this doesn't apply to us because it's youth, but because the definition it does. And also there's a smaller sliver that you have that are in the post-adjudicated status, but also important to recognize that because that also may pull you in as well to this piece. There is an additional state option to use Medicaid to cover comprehensive services. This is for the State Office of Medicaid to determine for folks that are pending disposition of charges. Just so folks are aware, we're not aware of any state that is taking that up currently. There is discussion across the country of this, but we're not aware of any state that's actually looking to implement what's called the 5122 option. I think we go to the next slide. So that was a lot of information to give you in a short period of time. So we like to take a breath and kind of dig in like a little bit further into the who, what, and when of these provisions. Again, due January 1, 2025. But under the who, folks have to be eligible for Medicaid or CHIP based on income and other factors that vary by state. Again, under 21 or former foster care youth under age 26. This is the focus population, post-adjudication, and within 30 days of scheduled release. And then the what? It's the two sets of services, the screening and diagnostic, which is physical, dental, behavioral health. One piece that I'll get into earlier, but bears mentioning now is, taking a look at the current screenings that you are conducting at your facility is an important first step, but we'll get into some of the details later on. Also, the targeted case management, for example, referrals to appropriate services. That's 30 days prior to release and then 30 days in the community. But the screening and diagnostic, as I stated earlier, that can happen 30 days prior to release or shortly thereafter. You can go to the next slide. So this is just a distinction that wanted to mention quickly because I think a lot of folks are like, how does this pair with what we've heard about with the waivers? So just wanted to give this overview, but the focus of this webinar today is going to be focused on the youth provisions. But for the first time, Medicaid can cover services when someone is incarcerated starting up to 90 days pre-release. But states must cover in their waiver proposal case management, medication-assisted treatment, and 30 days of medication in hand upon release. Currently, we have 13 states that have approved waivers from CMS, which is the Centers for Medicare and Medicaid Services, and that's California, Illinois, Kentucky, Massachusetts, Montana, North Carolina, which came last week, New Hampshire, New Mexico, Oregon, Utah, Vermont, Washington, and West Virginia just got approved last week as well. And so, but there's also 12 other states and DC that have pending proposals before CMS as well. We can go to the next slide. So this is the state option that I was talking about. Again, we're not aware of any states that are actively looking to exercise this option at this point, but this also starts January 1. States have the option to offer some Medicaid cover services to youth that are pending disposition of charges. In states that elect the option, facilities must provide the same comprehensive Medicaid benefits for children and youth that are eligible for in the community. So that's an expanded scope of benefits. If states were to take up this option, that would have to be implemented. These services would affect a larger percentage of the jail population than the required pre-release pieces of it. But again, we're not aware of any state that is actually taking up this option. But in case you hear about it, that's what folks are referring to as 5122. We can go to the next slide. Again, just wanted to kind of take a step back. And many folks on this call are aware of this, but I think, again, it's important to highlight there are some challenges, right, with the high number of individuals that are entering our jails with unaddressed behavioral health issues. And that is a daily concern, I'm sure, for a lot of sheriffs and a lot of jailers across the country, and how to address the needs of those folks that are in their custody. The one thing that we always used to say back when I was working in the jail, if you've seen one jail, you've seen one jail. So obviously there's variations in scale and infrastructure and capacity, based on county. Again, short stays, because if we have folks that are lining up for services 30 days prior to release, what if you have someone who's coming in on a short sentence of 10 days? So that is a challenge. There's high turnover in jails, stating the obvious. And there's variations in, care delivery and staffing, private vendors, public employees, and the rest. But again, this is a public safety issue. When you have an opportunity to point services to individuals, and if we connect them with the coverage and the care they need, then they're less likely to return to jail. And we go to the next slide. So again, wanted to take a moment, because you're probably saying, like, thanks, Ryan, you gave us a lot of information. Like, where do we go from here? Possibly starting with information gathering would be good. What we did when we first learned of this, when I was working at the jail, was we just started to dig into our data, like who's under 21, who's under 26, just to get on the sentence side, to see what the volume was going to look like. So we started with the data. And then also understanding how your facility tracks and communicates expected release dates, because that's going to be important, because you will have folks that are leaving with targeted case management. If they're leaving on supervision, how you're interacting with those supervision entities and the rest, and how you're communicating that not only across your facility, but also with your other state partners or local partners when it comes to things like supervision. Identifying what Medicaid enrollment and eligibility process you have in place right now. Like, what are you doing for Medicaid enrollment? How are you determining? You're not determining the eligibility. Obviously, the State Office of Medicaid is doing that, but what does that partnership look like? How's the information share set up? What MOUs do you have in place? Just doing that capacity review for starting to set yourself up for the implementation. And then again, understanding, as I mentioned earlier, what diagnostic and screening you're doing right now. And then you're going to want to get with your State Office of Medicaid, because they're going to determine what those services need to be. And you're going to have to huddle and collaborate on what services need to be delivered behind the wall. But again, that's the State Office of Medicaid that's going to have to determine what those services are in your respective jurisdiction. Again, because such a large component of this is case management, the targeted case management, there's a lot of obviously great case management that's happening in many jurisdictions across the country right now. You're just going to want to make sure that that aligns with the definition for targeted case management, which is a Medicaid definition. Because if you are in the situation where you become a Medicaid enrolled provider and you want to bill for it, you want to make sure that you're actually providing targeted case management under the Medicaid definition. Also exploring methods for tracking performance post-release, because if you decide as a correctional facility that you're going to provide the targeted case management pre-release and post-release, you're going to want to prepare for the performance metrics that you're going to want to gather. There will be certain requirements that you'll have to gather certain data, but also just setting up a matrix of information that you'd like to gather for your own edification as you work to implement these pieces. Also, technology and infrastructure, a capacity review of what you have for your electronic medical records, and also developing staffing matrices as well. Like, how many staff are you going to need to make this go live? Is it 3 to 4 that you'll need to help with the billing component or the case management pieces of it, someone to oversee and coordinate efforts with other partners? It's important to sit down to determine what your needs are and be able to communicate that with your State Office of Medicaid, as well as, like, these are our staffing needs as well. Next slide. So a big component of the where to start is obviously the stakeholder building. And I've said this a few times on this webinar, but talking to your State Office of Medicaid is the place to start. And also, exercising the relationships you have through your state associations, so that you can go as an association to the State Office of Medicaid with, here are your questions, here are your concerns, here are potential challenges, because corrections is going to have a line of sight into this, what the potential barriers may be that you can lift up and make sure that you're highlighting for additional partners. Also reaching out to your facility medical providers and community providers, because they're going to be delivering a lot of these services behind the wall, in getting their perspective on this, and doing exactly what you're doing today. You're coming to these webinars, you're connecting with peers, but also, again, connecting with your state associations and your national associations, as you're doing today, to provide your insight on some of the challenges that may be in place for you in the implementation. Because a lot of the work that HARP does is we listen to state and local, and we push that up to the feds. We also take what we hear from the feds and we try and share that with state and local, in and around specifically these issues, but also with the waivers. Next slide. So again, another piece that is important to highlight is there is currently $100 million in state planning grants available through the state office, through the Centers for Medicare and Medicaid Services. It's happening in 2 tranches. The first application date was November 26th, but states have another opportunity, if they have not done so already, to submit an application for these funds on March 17th of 2025. So again, when we talk about doing your capacity review and talking to your state office of Medicaid who will apply for these funds, going and talking to your director and saying, here are the needs that we have. There's a potential where you could collaborate on the proposal to be able to submit something to the feds that could help assist with, for example, let's say you want to utilize telehealth services, but you need to do some capital improvements within your facility. Some of those funds could be dedicated for the expansion of those services within your facility. And that could be a really great way of actually helping the implementation pieces of it, is actually utilizing telehealth. And this is just an example. But again, it will be important for you to talk to your state office of Medicaid. And also the range of the grants are going to be $1 million to $5 million within a cooperative agreement, and will last over a 4-year period. But we can drop it's a notice of funding opportunity, or a NOFO. We can drop that information in the chat for you so you can take a look. Next slide, please. So just in time for the holidays, BJA, the Bureau of Justice Assistance, partnered with HARP to develop a suite of materials for folks in and around these youth provisions for adult corrections. So if you're wondering what to get your assistant superintendent for Christmas, there is a whole list here that you could pick from, including frequently asked questions for jails. There's also a brief operational checklist for post-adjudicated youth you can take a look at. We'll also drop this in the chat for you. And there's also key elements to consider, 7 key elements for implementation, because we really value the fact that DOJ and the Bureau of Justice Assistance stepped in for their leadership in helping develop these materials, because we were on a listening tour, and we felt like having something like a checklist, like a punch list, like what do I need to know for the implementation of these youth provisions? We wanted to be able to provide that for the field. So do encourage folks to take a look at those. And if there are questions that come up, we'll provide our contact information at the end of this webinar so that folks can follow up with us directly if they would like to. And then I think, just to round out on the last slide, we do have an opportunity here in looking ahead. This is a major vehicle for improving the health of individuals as well as the safety of our communities. But implementation is going to be complex. This is not easy. It's going to be a lift, and it will take time, and we will need to make improvements along the way. But the stakeholder building is going to be critical for this success. And just to say it one last time, if you have not already started communication with your state office of Medicaid, I would do so today. So thank you so much. And kicking it, I believe, to Hannah at this point.
Thanks so much, Dave, and a big thank you to NSA and to HARP for your partnership on this work. So for folks who aren't familiar with NAMD, we are the National Association of Medicaid Directors. We represent the 56 Medicaid programs from the states, DC, and the 5 US territories. And we can go to the next slide. I'll just wrap around what Dave shared pretty briefly to talk through what Medicaid agencies are working on now and how you can best partner with your Medicaid agency on this work. So to level set, you'll often hear us say CMCS or CMS. CMCS is the Center for Medicaid and CHIP Services. They're under the kind of broader agency of the Centers for Medicare and Medicaid Services. But essentially, these are the federal agencies that regulate state Medicaid programs. So back in July, CMCS put out formal guidance on the statutory requirements at Section 5121 that Dave just walked through. The guidance included a lot of detail around who's eligible for the services, around what services need to be covered, et cetera. But the guidance also explained what Medicaid agencies need to have in place by January 1, by that statutory deadline. So first, Medicaid agencies need to develop what's called an internal operational plan and need to have that in place by January 1. The guidance includes kind of a list of elements that states need to include in that plan, but essentially it's a work plan that details how your state will implement the required services for young people who are leaving incarceration. And then states also need to submit what are called state plan amendments with effective dates of January 1. Basically, the state plan is the set of formal documentation kind of around what services your state Medicaid agency provides and to who. So that state plan amendment is essentially the formal approval process to kind of add or change Medicaid or CHIP services or populations. So your Medicaid agencies will need to submit state plan amendments to incorporate these new services for young people. We can go to the next slide. So we've heard from Medicaid agencies and from correctional leaders that there are really significant challenges associated with fully implementing these services by January 1. We know that likely not every state and not every correctional facility is going to be fully ready to go on January 1. So CMCS is planning to use a state plan amendment framework that seeks to balance the January 1 statutory deadline with some of these on-the-ground realities and implementation challenges. The framework is complex. I'll just touch on it briefly, but essentially the framework is going to use that state plan amendment process that we discussed on the last slide to kind of categorize states as fully ready, partially ready, or not ready. So states will submit those state plan amendments, and then CMS will determine if the state is fully ready, partially ready, or not ready to implement. A fully ready state would be one where every correctional facility is ready to go on January 1. They're delivering services to kind of all of the eligible young people. A partially ready state might be a state where some facilities are ready to go on January 1, but other facilities need some more time, or maybe where facilities are delivering the required services, but not yet ready to claim Medicaid reimbursement. We know that's an extensive process sometimes. And then a not ready state, as the name suggests, would be one where kind of no correctional facility is kind of fully ready to go on January 1. So the bottom line here is that there is the state plan amendment framework in place to allow Medicaid agencies to turn on claiming for correctional facilities that are ready to go, while creating a little bit of wiggle room for facilities that need additional time to come online. And Medicaid agencies are currently meeting with CMCS, so with that kind of federal regulatory agency, to talk through their readiness to implement and kind of which SPA pathway they'll be using, which of these fully ready, partially ready, or not ready pathways they'll be using. We can go to the next slide. So what are Medicaid agencies doing now, and how can you partner with them? So Medicaid agencies are very hard at work on planning for implementation of Section 5121. That includes, hopefully in all of your states, kind of meeting with correctional facilities, meeting with providers, deciding what exact set of services will be included under this benefit, deciding which providers will be delivering these services and kind of via which modality, working to set up things like data exchanges with correctional facilities to kind of make sure that you all know who's eligible for these services. and also setting up claiming systems so that providers can claim for Medicaid reimbursement on these services. As Dave talked through, states are also making decisions around optional services. So are they going to pursue the Section 5122 services, the optional services for pre-adjudicated youth, and then also the 1115 reentry waivers? States are developing those internal operational plans, so kind of their work plans detailing how they're going to implement Section 5121, and then also meeting with CMCS to talk through that state plan amendment pathway. One of the bottom lines here, though, is that Section 5121 implementation is going to look different across different states. We also, in the Medicaid world, always say if you've seen one Medicaid agency, you've seen one Medicaid agency. So different states are going to have different packages of services. They might use different types of providers. The data exchange is going to look different operationally. So to echo Dave, we know that it is essential that sheriffs and Medicaid are really actively partnering on this work. It's the only way that the implementation is going to work. We can go to the next slide. That, of course, kind of begs the question, how do you get in touch with your Medicaid agency? If you're with a sheriff's office or a state association and you've been struggling to find the right point of contact for your Medicaid agency, please feel free to reach out to NAMD. My email is on the screen, and we'd be happy to try to help find that right point of contact for you. And with that, I'm going to pass it to Margot from HARP to introduce our next speaker.
Great. Thank you so much, Hannah and Dave, for all of that information. We are going to take all that we have just heard and turn a little bit towards what's happening in the real world, starting with Mike Levine, Assistant Secretary for Mass Health, who's the State Medicaid Director of Massachusetts. Mike, I would love to hear a bit from you. How has the work been going in Massachusetts to implement this policy?
Sure. Thanks, Margot, and thanks for having me here. And thanks for everyone for making the time to tune into this very important topic. I think, Dave, hailing from the Massachusetts sheriff's scene, I think put it correctly when he emphasized collaboration. We've been at various forms of partnership with our sheriffs and our Department of Corrections and our Medicaid agency for the better part of 5+ years. But I think that the reason it is so critical and that we have been so focused on building kind of deep and meaningful relationships with our correctional partners is really two reasons. One is they're inviting us into their homes when we do this work, right? The work is happening behind the walls. And so if we, the Medicaid staff, don't take time to understand workflows and staffing and how their contracts are set up with their healthcare providers, and we don't actually come out and visit, it's impossible for us to move this work forward in a way that we're actually expecting, inmates before and after release to get better services. The second reason why I think the emphasis on our end has been on really collaboration and relationships with our sheriffs is because healthcare and the correctional system were not built to work together. At every meeting we have, I feel like my brain has gone through a washing machine because trying to figure out how to line up the IT and the data and the claims and the quality measure, like everything, we use two different sets of language. We are all trying to solve the same problems. That's good. We have the same goals in mind, but it takes a lot of work to get these things to line up. And we're very fortunate in Massachusetts to have incredible leaders on the correctional side. Carrie and Dave are two of them, but to have leaders who want to get to the same place and frankly have been at it for years, long before the CAA was enacted. To get clear on what that means, right? Because collaboration is kind of a trite and overused word. We are meeting with Carrie and the sheriffs all the time. There are weekly touch points. I was just on with all the sheriffs yesterday, trying to understand, okay, CAA is around the corner. What are you most worried about? Where are the gaps? How can we address them? We've deployed a survey and a checklist around CAA implementation readiness. Our team's been out to 12 of the 13 sheriff's offices in the past year or two to do on-site visits and talk to providers, in some cases talk to inmates and talk to COs and talk to the sheriffs and their teams about what they're seeing and what they're worried about. And we've spun up a number of work groups that are on kind of specific topics. And so I think the level of engagement has been really important because, we at the Medicaid agency, we always learn more than I think we have to offer in a lot of that engagement in terms of how this is actually going to play out and how we can partner best to make sure that the care is being delivered on the ground. If just to share one or two examples of kind of specific gaps that have arisen or kind of challenges we need to solve together as a result of that engagement, the clearest one in my mind, because we were just talking about it yesterday, is how to identify former foster care youth. So if you're a sheriff, right, everyone who's under age 21, that's not hard, but you got everyone between 22 and 26, and people don't walk around with a name tag saying I'm a former foster care youth. It's not necessarily practical to ask everyone, but I'm at Health and Human Services. I'm next door to our Department of Children and Families. We can make those data available if we get the right IT people together, if we get the right privacy lawyers together, if we get everyone together to figure out, okay, how can we kind of efficiently and accurately convey this information so that there are only, you can kind of winnow the post-adjudication population down from, X to 10% of X who are former foster care youth. So that's an example of like a very specific problem that we've kind of taken on together and I think are going to be able to solve. I think another example is post-release case management. So again, we're very fortunate that in Massachusetts, I think even years before the CAA was enacted, the sheriffs and the counties have been doing a lot of pre-release case management. In fact, we launched for the most acute subset of the population, something we call BHJI. It's basically intensive case management for individuals with acute behavioral health needs. We launched it in a few facilities in 2019, went statewide in 2021, but that solved kind of, and it's a great pre-release, the case management begins behind the walls and then extends out once the individual comes into the community. So that's a great model. I think now we're all kind of scratching our heads of saying, well, that level of intensity is not going to work for everyone. So what's a different program model? Maybe same providers, same players, but how do we tailor that model to the broader population that's reentering? And I think because we've been at this for so many years with our partners, we're able to, get around the table, figure out what the gaps are and how to address them. So as we head to 1125 with the CAA, I think we're in really good shape. And this is kind of on the path to full implementation of the Reentry initiative, where we are running the traps on how the financing is going to work, how pharmacy is going to work, how the case management model and the screenings and all these pieces are going to work across a much broader population so that later in 2025, we're launching facilities and actually getting up and running and seeing what we learn along the way. So I think it does come back to the relationships. We're very lucky to have great partners, and we just want to keep that partnership in place so that as we learn, as we adapt, as we need to pivot, we're doing so in a very transparent and predictable way.
Mike, that's so helpful. Knowing that Massachusetts has this long history of collaboration, starting with that behavioral health initiative you mentioned, do you have any advice for sheriffs and correctional administrators who are maybe much earlier in their relationship with their Medicaid agency, and any advice for starting to build those relationships from ground zero?
Yeah, invite your Medicaid leadership out to visit. I've very much enjoyed and learned an enormous amount about how things actually work when I've had the opportunity to go visit a couple counties. I'll share just thinking of the two most recent visits I've done. The model's pretty different, but they're both really interesting in terms of how the facility bridges community providers with the kind of in-house, kind of behind the wall medical care. And I think without kind of sitting in the room with the clinicians, understanding, okay, kind of this is the point at which you connect behind the walls versus how you try to catch someone when they come out. Without understanding that, I don't really know how this works. It's very abstract and just kind of sounds like a lot of work and pretty complicated. So if you can actually get the Medicaid staff on site, I think they'll learn a lot And it's also a good venue for the correctional partners to say, look, these are the 3 things I'm most worried about, and you can understand why. And this is my day-to-day, and it's really constructive.
It's fantastic concrete advice, Nick. Thank you. We're going to turn now to Rick Bishop, jail liaison for the Washington Association of Sheriffs and Police Chiefs. So Rick, you've been working with adult facilities in the state of Washington for a while. Can you talk about how sheriffs and jail administrators in Washington are thinking about implementing these changes?
Certainly, and thank you for inviting me today. I appreciate it. Just a little bit of background about me. I'm a retired chief deputy with an emphasis in corrections, 40 years in a variety of roles, 830 beds, 2 facilities. WASPC, Washington Association of Sheriffs and Police Chiefs, picked me up a few years ago, 4 days after retirement. Don't answer your phones, folks, if you retire. Change your phone number, change your email address. My current function as the jail liaison is basically to translate from our elected officials to sheriff. I speak fluent sheriff, and I'm paired with a MD here in the state of Washington because I don't speak medical. So between the 2 of us, we've been working now for almost 12 months, specifically on the waiver 1115. I can speak to the juvenile a little bit because of the 21-year-olds and the 26-year-olds, but we've run into some major things that I wanted to share this morning from the Pacific Northwest. Sorry, folks, for the East Coast. First of all, we've got about 50 jails. We incarcerate at any day 8,400 people with an average length of stay of 18 days. Approximately 77% of our population is pretrial. Of that, 61% have a substance abuse disorder, 58% have a mental health disorder, and 41% have co-occurring. I think those numbers are low myself, but that's what the AG's office gave me. 75% of our jails are 250 beds or less. We cover jails from 3,000 beds up in Seattle to 2 beds out in the San Juan Islands. And they're going to double their capacity to 4 beds here real soon. As a result, most of our jails do not have 24-hour medical care. They don't have 24-hour pharmacy. They don't have any type of discharge planning to speak of. They're trying to do reentry work. And most of our people get out in the first 72 hours. One of our studies shows that 50% in the first 72 hours, and then from the next 27 days, all but about 5%. So David's comment about a quick turnaround is immensely understated. Our jail administrators are highly concerned on what we're going to do from that period from 72 hours to that 7 days. That's when the next major group gets out, and they don't have much time. And before I go any further, I use 2 different terms. I use discharge planning for people who want to break the cycle, and I use release for people who want to victimize our communities. You'll find that I come from the ground level. I started in patrol, went to jail, went up the chain, did a bunch of different things. And my personal belief, if I'll get off my soapbox, is reentry starts actually in the patrol car with us interviewing on that long or short drive back to the booking facility, that person on what led them to this, and then explain to them what programs the jail has available to break that cycle. If they want to break the cycle, we'll help them. If they don't want to, I've been quoted as saying, I'll find you a bed. It's not a problem. I'm not going to let you victimize my community. If you get a chance, well, before I go on there, I'm assuming that most of you on this call have a real concern about release, or discharge and release. My experience is people in that 40 feet from my front door to out of custody supervision get lost. They can't find their way, much less to their first SUD appointment. So one of our challenges has been what's called the warm handoff. I may be preaching to the choir here, but we have found that unless we get peer mentors people with lived experience who can go into the facilities and establish a relationship pre-release. And of course, that has to happen quickly because we have a real challenge, and your jail administrators are going to talk about unanticipated releases, bail, recog, drop charges, and they're out the door like that, and there's no notification. And I know that it's trying to explain that to folks who are outside the correctional or law enforcement system is really tough to understand that when the judge says release them, I don't have an option. I can't stop it. I can't do anything about it. I have to release them. And a lot of people just run out the door. But continuing, we need to get those peer mentors. And one of your first challenges, at least our experience, has been getting our staff to accept someone who was previously incarcerated, who now is off paper, who now has gone through our clearance process, coming back in and interviewing people. They're really concerned about contraband. They're really concerned about undermining their authority, and they just don't trust. So as part of your planning process, you're going to have to really work with your staff, at least we've had to, in our facilities to have an understanding that we need to do this. And I'll get to public safety in just a moment. Next, our next challenge has been the 30-day medications in hand under the waiver. And a lot of our jails just don't have that, much less they don't have 24-hour pharmacies. We have some very, very remote jurisdictions in different parts of the state that we're trying to figure out right now. And the doctor I'm working with has suggested PIC machines, those type of machines that the pharmacy can call in or pharmacy can log in and get that medication ready. And that can be easily then, I'm told easily, accessed in the middle of the night, Saturday night at 7 o'clock when someone's bailed out, they can get their medication. I'm going to stop right there and just do a quick statement about the other challenge that a lot of our jails and sheriffs are trying to wrap their heads around, and that is not only do they not have 24-hour pharmacies, they don't have any kind of substance use disorder programs in their counties. We are setting these folks up to fail if we don't get them to a program in those critical first hours. David said 72 hours. I think it's even shorter, but that's just my experience out there. And I'm going to talk just briefly about why this is public safety, and then I'm going to go quiet. Jails have had to accept in the state of Washington that we are now a major public health player. This is a new role for us. We've had to learn, and it's the hard way, that if they're not in the ER or ED and they're not in the shelter or on the street, they're in our jail. Second, we are a major player in point of service of mental health, medications, just medical services in general. We need to address the days of locking people up, opening the door back up, pushing them out the door and saying good luck, and we'll see you on the flip side, should be over at least. We need to accept that we're that major public health player, that a lot of people who are in need are in our facilities, and we don't want to be that major player. We want to help people break the cycle. And I'm going to say something else. Relapse is part of recovery. I'll share it here nationally. I do it at my own state. In February, I'm 20 years without taking a drink. And I'm just one of the fortunate ones. But relapse is part of recovery. And we have to have our staff learn that when you release somebody and they come back, okay, let's figure it out. And Sheriffs, the idea is if they come in 10 times in your jail in a year, and your average length of stay is 18 days, and you can get it down to 5, well, you've gone from 180 to 90. And you're freeing up jail beds for those people who want to victimize our community. That is the key, at least that we have found, that we are doing to free up those scarce jail beds. We're having a hard time building them, and those scarce tax dollars. So if we can get these people to break the cycle, and we can get them the help they need, and I'll go further, it's not just medical. I mean, our studies showed it was housing, public, this is long before the national narrative, childcare, transportation, just a list of things, basic education. If we can get them where they're at their lowest point, and get them what they need, we can help them break the cycle, and eventually we'll reduce their jail bed days and keep those beds open for those who truly want to victimize our community. And now I'm going to stop and take a breath. Margot, I'll turn it back to you.
Rick, thank you so much, both for articulating some of the real operational realities, of how this policy goes from paper to practice, as well as just talking more about the public safety opportunity here and the public health opportunity. I think we have a couple more minutes for Q&A, and I really welcome folks to drop their burning questions in the chat. Just to keep us moving though, David, I'll start with you on this, but I welcome Rick and Mike to jump in too. We've talked a lot about the services that need to be happening behind the jail walls and in the community. Can you speak to what you think the role of probation and parole is in making these policies a reality?
Yes, Margot, thank you for the question. So where my mind goes in this, if I am a probation officer, is I'm going to realize that folks are coming into the community and they're going to have targeted case management. I'm going to want to figure out who is running that targeted case management. It could be a community-based organization. It could be the correctional facility that's deciding to do that targeted case management. But I know I have that individual who's coming back in the community on supervision. So I'm going to want to step in and collaborate. First and foremost, most likely with the correctional facility would be the first step in my mind. But also when we talk about stakeholder engagement, if I'm probation or parole, I'm going to also probably want to reach out to my Medicaid director as well to help facilitate the coordination in and around those services. So we do talk a lot about cross-agency collaboration. The start, right, is correctional facilities with your state office of Medicaid, but it's not just us, right? There's many other stakeholders that need to be at the table, including folks with lived experience, because one thing that we did back when I was working at the jail was that we actually sat down with a group of gentlemen who were currently incarcerated, and we explained the whole thing to them. And we said, okay, like in your reentry plan, like what would have been helpful? Because I will say a couple of these folks were guests for the second time, if you will. And the gentleman said, listen, I'm a new dad. I'm taking parenting classes at the jail right now. Is that something that Medicaid might cover in the community? Perfect question. And I'm so glad that we actually had that focus group, because that really helped inform us of those pieces. And with just the global point of a diverse set of stakeholders, including parole and probation, having them at the table is going to be critical as well.
Mike or Rick, anything you'd want to add to that?
Understanding transportation. They may have some type of a limitation on travel or reporting. If you're up in Ferry County, which is in the northeast part of our state and up against the Canadian border, and the closest methadone clinic is Spokane, they're going to have to understand and make allowances for that transportation, and making sure that they accommodate the trips, the family, vouchers for buses, whatever they need to do, and then weather. I mean, those folks are up in the mountain passes, so that's they can't be as rigid. And I go back to my comment: the days of pushing someone out the door and being punitive are over. At least they should be, at least just for the small group that need it. But they need to be understanding of the services and where they need to go.
And I think it also speaks to the Medicaid agency's need not only to be really close with the correctional partners, but also with our providers. So I think Rick's example of how the heck am I supposed to get to my, weekly or daily methadone clinic, here in Massachusetts, particularly in the western rural part of the state, we're starting to think about mobile, paying a little bit more to get our outpatient treatment programs mobile. And it would make a lot of sense for us to then connect the dots between, if you've got a handful of methadone providers in the western part of the state, connect them on the justice side so that we're actually able to make sure that these people are the ones who are getting the mobile visit. So I think that continues to be important. It's just hard. It's just a lot of players who don't speak the same language to wrangle. But if it's around a shared problem, like everyone can understand the example that Rick just shared. So when you kind of zero in on it and take the time to understand each other, I think that's where you can get to a common solution.
Yeah,
that's
great advice. Yeah, please.
Can I add to that?
Sure.
That partnership we have with the medical doctor, that has been, when you talk about translation, he translates to me, I translate to him, because Medicaid is just as bad as the FBI with their acronyms. I understand FBI, I do not understand medical. And I mean, I'm forever searching up y'all's different acronyms. So that communication is key. If there's, the sheriff's listening on this, I've told my folks, if you pissed off your local health department, walk across the street now and make amends. Let's get going. So.
Thanks, Rick. And I would imagine that Mike and Hannah might feel similarly about some of the acronyms and jargon in the corrections world. So we just have a few more minutes left. So I'm going to kick it back to Carrie to bring us on home. Thank you, Rick and Mike.
Thank you, and thank you all. And just a couple of things as we kind of begin to wrap things up. We hear the importance of collaboration, and we have, as you've heard from both Dave and Director Levine, this importance of working together, and as we have been. A couple other things to think about for some of the sheriffs on here who are kind of wondering where to begin, and definitely by reaching out to your Medicaid director and partners. One of the other great partners that we brought to the table was working with our Division of Youth Services, whoever that is in your state. And one of the things too that can be very helpful is if you're looking at some of the services or some of the screenings and some of the diagnostics and targeted case management, your Division of Youth Services may also too have some ideas about what they have been doing and what they're currently doing, and ideas of being able to replicate some of that could be a possibility as you work with your Medicaid directors on that. So they've been at the table with us as we've been talking and really understanding about what are some of the screenings and diagnostics and targeted case management to be thinking about. Also too, if you're not as sophisticated yet, where not everything is, we'd all love everything to be, IT and, we can share data. One of the beautiful parts of all of this is that there may be reentry dollars to help build out that technology, but what can you do in the interim? And one of the things that we're looking at is it might just be a workaround for a short period of time for the sheriffs and the DOC to send the list of individuals between 22 and 26 to our Medicaid partner to help determine eligibility. So think about ways that maybe years from now is where you want to be, but what can we do in the interim to first identify these individuals, and then what type of screenings, what type of diagnostics and targeted case managements are we currently doing? Will those work? And if not, who are some of our partners maybe we could learn some more about that maybe we could do telehealth services with to provide some of those screenings and some of those diagnostics. Again, working with your state Medicaid director and the team can help us, because I think you're going to be further along than you thought you were. But by talking and working together, it's really an extraordinary path forward. So think about taking, as Mike talked about, sometimes it's smaller steps together, and you'll find out that this enormous initiative is not as enormous as it feels. But again, pieces at a time, working together. So with that, I want to thank all of you for being on today. It's a very, very important conversation. In the PowerPoint deck and the link that we will send you in the next day or two, you have everyone's contact information. Please know that our national partners, the National Association of Medicaid Directors, the National Sheriff's Association, and HARP are all there as extraordinary resources. The resources that Dave outlined that HARP worked on, with BJA's assistance, they're extraordinary for you. So this conversation doesn't have to end here today. Please reach out to all of those different resources. So again, on behalf of the National Sheriff's Association, on behalf of the National Association of Medicaid Directors, as well as HARP, as well as our guest speakers, Mike, thank you so much. And thank you personally for the work that you have done and to help really to lead that coordinated effort together. I say thank you. And I appreciate you and who you are, not only on this call today, but who you are to all of us in Massachusetts. And Rick, thank you for the work that you are doing. And I'm glad you came out of retirement. So with that, thank you all. Have a really healthy and be safe this afternoon and in the upcoming weeks. And we will make sure to share the links to this webinar and all of the resources with you in the upcoming days. So thank you.
Thank you so much.
Thank you.